thank you for the opportunity. I think we are shifting from a 70-year-old to problem of small children. So we all know that biliary atresia is quite common, occurs in 1 in 10,000 to 15,000 deliveries. It's a progressive fibro-obliterative disorder of intra and extrahepatic bile ducts. Generally, its onset is within the first 3 months of life. So what is the treatment for biliary atresia is usually Kasai portoenterostomy, first described in Japan. But we need to remember one thing, KPE solves only the extrahepatic issue. So intrahepatic bile ducts paucity or absence is not addressed. Majority of these children after KPE develop ESLD and require liver transplantation in the future. So what are the indications for liver transplantation in a child with biliary atresia post-KPE or a missed child who has missed the procedure? Late diagnosis, failed Kasai, significant malnutrition, recurrent cholangitis, progressive portal hypertension, severe pruritus, hepatorenal syndrome, and HPS and POPH. In the right side, I have depicted what all the complications these children can have. So the native liver survival comes down as they grow older and older, and the rate of complications increases. It's a cumulative complication. It is not that one complication occurs after the other, can happen simultaneously. So what is the current paradigm of management? We have a jaundice infant. We hepatologists make sure that it is a conjugated jaundice and obstructive pattern in the liver biopsy. So pediatric surgeons do an intraoperative cholangiogram and proceed with hepatoportoenterostomy. If they remain anectric or if there is evidence of bile drainage, we just follow them up with supportive treatment. Few children present late, around 25 to 30%. In Indian scenario, almost 40% present late presentation. They have cirrhosis at presentation. These children are directly taken up for transplant. So after Kasai, there are a subset of patients who doesn't demonstrate bile drainage. They also need transplant. Whoever have had successful Kasai, as I depicted in the last slide, they fail subsequently and they need liver transplantation subsequently. So what is the likelihood of successful rates of Kasai? It varies from region to region. So it varies from 26% to 47% at 10 years when we look at the native liver survival. So it's very important to remember that jaundice clearance doesn't ensure transplantary survival. You know, these children can have other complications, which I mentioned in my first slide. So I have depicted the 40 years native liver survival in children who have undergone Kasai as children. It is around 20 to 25%. So we have a child here who has been diagnosed to have biliary atresia beyond 3 months or at 4 months. What do we do? So late diagnosis of biliary atresia, it is a definitive indication for liver transplantation. So the benefits of early Kasai have been beyond proven doubt, are well established. Late Kasai is vaguely defined as, more than 90 days, more than 100 days, more than 120 days, have very long-term low native liver survival rates. You can see in this graph, the green line is just dropping. Those are the children who went Kasai beyond 90 days. So KPE should be avoided in children with cirrhosis and ascites, as it can precipitate decompensation. It worsens the liver disease. This is our own experience. Group 3, beyond 90 days, we did Kasai. They all had very poor outcomes with the native liver survival less than 25% at 5 years of age. So what is the timing of Kasai when you have a child who has missed a KPE? So try to look at the literature. Probably around 6 months of age, weight around 5 to 6 kilos. That's what everybody has been practicing. And the results are comparable to LT for failed KCE, LT with failed Kasai portoenterostomy. So probably we would wait for the child to gain some weight, probably around 5 and around 6 months. So, and we need to complete the vaccinations also. I would wait around 6 to 7 months and then probably take this child for primary liver transplant. Then we have a subset of patients who fail, group of patients who have early failed Kasai. So the natural history of BA plus failed Kasai is equal to that children of unrepaired BA. So 2-year LT-free survival, we can estimate by the bilirubin at 3 months post-KCE. If the bilirubin is less than 2, their 2-year LT survival, 84% of these children will survive with a native liver. If it is more than 6, unlikely that they will survive with a native liver. So children who does not clear jaundice by 3 months KPE, evaluate them for early Kasai portoenterostomy, ideally by 6 to 9 months of age. So we have another subset of patients where we call them as medium failure group. So around 40%, 45% we have early failure, they fail within 1 year. So we usually transplant them, as I told earlier, around 7 to 8 months of age. So then we have medium-term failure, around 40%. So the indications are varied. It is just not only jaundice, I explained in the first slide. It can be cholangitis, it can be GI bleed. As they grow older and older, the other complications set in. So these children also would need a transplant, probably, around within 2 years of age, between 1 to 2 years of age. Then we have something called long-term failure, around 15% fail for various reasons. Most probably it is portal hypertension, GI bleed, and hypersplenism and ascites. So these children also need transplantation beyond 5 years of age. I won't be able to give exact numbers, how many percentage would need transplant at particular age after 5 years, because it depends on what complications they have. So then we have a subset of patients who will have failure to thrive. So they clear jaundice, still they can have failure to thrive. They can have jaundice and malabsorption and failure to thrive. So they develop this malnutrition despite they clear jaundice. So for post-KPE children with significant malnutrition, we consider liver transplantation in case of refractory failure to thrive with despite aggressive nutrition support. We usually, these are all our children who have had Kasai with jaundice, without jaundice. We put an NG tube down and then feed them, irrespective whether they have cleared jaundice or not, and try to correct it. If they are refractory, around 6 to 8 weeks, we try exclusive, NG feed nutrition. If they don't recover or if they don't gain weight, we consider them for transplant. Another important indication is these children are prone to have metabolic bone disease. Some few children present with multiple fractures. That is another indication for liver transplantation. Another complication is bacterial cholangitis. At least around 50 to 80% of Kasai children experience one episode of bacterial cholangitis within first 2 years of life. The good the biliary drainage is, the lesser the cholangitis. As you can see in this graph, more than 3 annual cholangitis episodes independently predict the need of liver transplantation. So 25% of these children will have multiple episodes of cholangitis. When do we consider recurrent cholangitis despite aggressive antibiotic therapy? So these children, if they have cholangitis, they need antibiotic therapy for 4 to 6 weeks. Multi-resistant bacterial organisms, episodes of life-threatening sepsis, and severe impaired quality of life secondary to multiple hospital admissions. Portal hypertension, little bit of gray area. Many children develop progressive liver fibrosis and portal hypertension. Around 67% of the children with post-KPE, despite clearing jaundice. 90% will have varices when we do endoscopy in these children, and 30% of these children will have one episode of bleed. Although we don't practice surveillance endoscopy, there are a lot of non-invasive markers where we can detect portal hypertension, and portal hypertension is universal in all children who survive into adulthood. So when do we transplant them? Prepare the family for LT as soon as one sign of portal hypertension is clinically evident or endoscopically evident. If the child has high-grade varices or first episode of bleed, consider LT immediately. So this King's looked into children who were survived with native liver beyond 16 years, how many of them had portal hypertension. Those who had portal hypertension needed liver transplantation within 4 to 5 years. So portal hypertension also independently predicts the need of LT even beyond 16 years of life. So pruritus, few subset of children, despite clearing jaundice or even with jaundice, they will have pruritus. So it can be significant enough to impair the quality of life for both patient and family, because parents have to scratch them whole night. So generally we manage them with UDCA, rifampicin and naltrexone. LT is considered when there is severe impaired quality of of life secondary to pruritus. Child is not able to go to school because of pruritus and failure of medical management. 7% and 3.5% of post-KPE patients develop HPS and POPH. These are self-explanatory. These children need liver transplantation at the onset. So every child who comes for follow-up in the OPD should be screened by a pulse oximetry. If there are new onset symptoms, we need to do a bubble contrast echo. We may feel a bit of a surprise, but these children are prone to have hepatic malignancy also, around 1%, and it can occur as early as less than 2 years. What I have depicted is the data from King's. 5 children out of 387 biliary atresias had hepatocellular carcinomas, and 4 of them were less than 2 years. Elevated AFP or concerning lesion should be evaluated further. LT is indicated in absence of extrahepatic disease or gross vascular invasion, irrespective of the size and size of the lesion and number of the lesions. So I highlighted what complications can happen. Can we base our decision based on the PELD score? So there's a UNO's data. Patients who had PELD of more than 17, more than at least 15, had considerable survival benefit in the terms of life years gained from LT. There are drawbacks of using PELD score for children with biliary atresia. They can often tend to have normal, PELD scores because they have near normal albumin or INR. Weight measurement is not reliable, artificially elevated because of organomegaly. They have a lot of ascites. And PELD doesn't account for complications of biliary atresia like refractory ascites, variceal bleed, and cholangitis, especially older children where they present with these complications. So there is a nice study, they tried to look at, to determine the optimal timing for liver transplant for biliary atresia using a Markov model simulation test. They divided into 3 categories: PEL less than 15, PEL between 15 to 25 with or without one complication, and PEL more than 25 to less than 25 with one complication. So there were patient survival rates after 10 years were 84% and 75% in moderate liver disease and severe liver disease. So there is a benefit of transplanting these children when the PEL score is between 15 to 25. Probably they have survival advantage. So I kept on telling, these children will have complications, they need transplantation. Why don't we avoid transplantation and consider them all for, transplantation when they present to us further instead of doing a KPE? So what are the advantages of primary LT rather than a salvage LT? So it can eliminate a potentially possible futile intervention with a 40 to 50% chance of failure within first 2 years of life. And there are a lot of advances in pediatric liver transplantation. We can do a safe transplantation and major procedure before complications, like before having portal hypertension, before having cholangitis. Can we do it? Yes, it can be done. I'll discuss in a couple of slides. So what is the disadvantages? Higher incidence of vascular complications or large size syndrome in smaller infants. I would have recommended, as a pediatric hepatologist, I would have recommended liver transplantation for all children with biliary atresia, provided they were not being exposed to immunosuppression and there was no risk of PTLD. This prevents us from recommending primary liver transplantation. We need to postpone as much as possible the possibility of LP. So what are the arguments for KPE first followed by liver transplant? That is salvage liver transplantation. KPE has less operative morbidity. I think everybody would agree. KPE may avoid the need of LT at least in around 15 to 20% in the long run. In case of sequential liver transplant, KPE provides us an opportunity for children to put on some weight, better, it will improve their nutritional profile, they will have more stable liver functions, and it gives us an opportunity to vaccinate all these children. So this is a study. Group A had KPE, Group A didn't have KPE. So you can see their weight, their PEL score, the hemoglobin, albumin were all better in children who underwent KPE compared to children who did not undergo KPE. And sequential therapy, especially in our setting, has economic benefits. Universal primary LT, it will likely to drive up healthcare costs. KPE first allows for the postponement possible LT financial preparedness for the family, but we have limited data. We need to look into this more carefully. There is social aspect, it allows patients and family to mentally prepare for life-changing LT. Prior KPE experience of a jaundice-free interval will elevate their mental status. Caregivers reported significantly higher lower Hamilton anxiety scores after KPE. So primary LT, there are challenges, small recipients, few more slides, I'll finish. Portal vein hyperplasia, there are associated anomalies. Earlier reports said there are higher risks of vascular complications and large for size syndrome, as I mentioned earlier. This have shown in the previous thing, the complications rates are comparable or the outcomes are comparable, primary or salvage LT. So when we look at a larger group, LT results were better in older children who had successful KPE than in infants who had derived no benefit from earlier surgery. So what do we need? We need to know. We need some guidelines which we can, or when we need some parameters which will tell us whether this KPE is successful in this infant or not. I've told earlier, age at presentation 90 days, no KPE, because each 1 day increases in the age at KPE increases by 2% that likelihood of transplant-free survival. If at presentation a child with biliary atresia has PELD score of 9, unlikely that the KPE is going to benefit. Ascites, nodular liver at presentation, APRI, a surrogate marker of fibrosis, all correlated with clearance of jaundice. Syndromic variant of biliary atresia have uniformly poor prognosis. Liver histology, the more fibrosis, generally most of the KPE children would have had a biopsy prior to surgery. That's what we do. So if it is a severe fibrosis, severe cholestasis, severe lobular inflammation, unlikely that the KPE is successful. There are inflammatory markers, there are newer markers which I don't touch because we don't practice them in India. So there is a nice score called infant biliary atresia liver fibrosis score based on patient's blood parameters. If IBAL score is more than 5.27, probably this child is a potential candidate for primary LT rather than a salvage LT. So coming back, so KPE plus sequential LT will delay the liver transplant, helps in weight gain, stabilizes the diseases. It's a less morbid and cheaper procedure. Potentially can avoid in LT in around 20% of the patients. Social acceptance, yes, it's questionable. Whereas a primary LT, it avoids extra surgery, avoids long-term complications after KPE, faster surgery, lesser blood loss, less reoperation, bowel and biliary complications and infections. So, and lastly, primary LT and salvage LT for early KPE failure have similar results. So we need to predict which child has got chance of early KPE failure and then decide. To summarize, KPE, SLT or PLT, age less than 90 days, definitely KPE followed by sequential, plus or minus sequential LT if needed. The gray zone is what do you do if the child has got high PELD score at presentation, low GGT has uniformly bad prognosis after Kasai, high APRI and syndromic, where we're going to do KPE or primary LT, that is little difficult to decide. Primary LT, definitely if the age of presentation is more than 90 days, if the child has ascites, nodular liver at presentation, definitely we're going to go for primary LT. So it's to conclude this part of the topic, BA, sequential therapy or versus primary LT, it's complementary. They're not competitive to each other. Decision should be guided by the patient's age, liver tests, and the expertise what we have. Probably we need an RCT, which may not be possible. So this is the last slide of my talk. To summarize, when do we transplant a child with biliary atresia? Late diagnosis of BA, primary LT around 5 to 6 months of age, when the child has got reasonable weight of 5 to 6 kilos. Failed Kasai, you have an early failure, we transplant them around 6 to 9 months of age. Midterm failure, 1 to 2. Long-term failure depends on onset of complications and what complications these children have. Portal hypertension, I would say if it is a mild, introduce the idea of liver transplantation to the parents, evaluate them for LT. Moderate to severe, consider urgent LT. Failure to thrive, as I explained, failure to gain weight or poor growth despite aggressive enteral nutrition for 6 to 8 weeks, an indication for liver transplantation. HPS and POPH, at the onset we have to do liver transplantation. HCC at diagnosis, cholangitis, recurrent cholangitis, MDR organisms, poor quality of life. PELD score, yes, we can use, but we should need to remember that it has got pitfalls in children with biliary atresia. Best outcomes when the PELD score is between 15 to 25. Thank you.
Thank you, Dr. Somashekar. Any questions from the audience?
Good morning, Dr. Somashekar. Being a pediatric gastroenterologist, I think the problem that we are facing these days is this 90 days criteria. So many times we come across children who are preterm, where we are calculating the corrected gestational age and even crossing the limit of 90 and going up to 100 days. And then the other set where we get across children at 74 days, 84 days, where we know their liver biopsy is 4/6. We know the liver is firm on palpation, probably there is albumin is 2.9. So at this individual approach, when you see, because we know biopsy is also somewhere a sampling error. You know, it's just one part that we are taking. So do you feel that a diagnostic lab would have a role to say whether a surgeon wants to proceed with Kasai, or he just does a diagnostic lab and he feels that no, probably the child has more risk of decompensation post Kasai, and let's leave the child at that stage?
Yeah, I showed you a couple of features in the histology. If there is a lot of fibrosis, you know, I will go back to that slide if you want. So, see, if the fibrosis is very severe, 4/6, what you say, and if there is a lot of cholestasis and there are a lot of lobular inflammation in the biopsy, look at for all these three features. If all these three features are there, it is better avoided. And especially if the child is presenting late, around 80 days or 90 days, it is better avoided. That's what I would say. Because Kasai in a child who is already decompensating will make them prone to get more cholangitis and they decompensate fast.
So would you
there
just
is
go
no
by
benefit.
biopsy, or would you also go ahead with a diagnostic lab and then take a final decision with the family?
You have biopsy with you. You don't have to do a diagnostic lab. If you are still, you know, you have biopsy which is equivocal and you have a low albumin, then probably you can do, you know, open up and see.
Because refusing a Kasai less than 90s is also controversial.
Sorry?
Refusing a Kasai just based on biopsy and LFT will also be controversial less than 90 days.
Yeah, this is definitely a gray zone, but you have to put everything together and see. I mean, if you're really confused, probably yes. Many times we also have opened up, we have felt that the liver is cirrhotic. Even at 60 days, 66 days, we have abandoned the procedure.
Yes. That was my point. Thank you so much.
Any other question? Dr. Sona?
My question really was about how successfully have you ever managed to get people to put on weight? Because we get a lot of these kids at 4 to 6 months who've had a Kasai, who are decompensated. And we try to build them up, so to speak, over 4 to 6 weeks. It's not been successful in our hands.
These children won't put on weight just with oral nutrition. They don't eat at all. You know, there is ascites, there is portal hypertensive gastropathy. Even if you give them, you know, they don't eat. The stomach capacity is limited. What they eat is very, very less. On top of all these things, parents have, you know, you should not give that, you should not give this. So generally what we do is, when the child with post-KP either waiting for an LT or they present with low weight, we put them on an NG feed. We educate, we admit them, we educate the parents for a couple of days in the ward and then send them home. What is the main worry for the parents is social acceptance, and what we are worried about NG feeding is aspiration. So many clinicians are against NG feeding because there is a risk of aspiration. So we always use litmus papers to check the gastric pH. So we have been successful in that model. Many children have put on weight. At least they have put on 1 kilo or at least 900 grams, so that they have some weight when we actually take them for LT. We have established some model like this.
Sure. I mean, I'd like to know, because we've been very unsuccessful there.
Yeah.
Because every time we try NGs, they put on some weight. After that, they get one episode of cholangitis.
Yeah.
Then you lose ground immediately, you know.
That's very much true. We give them enteral nutrition for 6 to 8 weeks. They're not gaining. They're proceeding with complication, then we have to just go ahead with the LT.
Yeah,
Nothing
so-
else can correct.
Correct. So I mean, we have a low threshold for going
Yes,
ahead very
yes.
rapidly. So
Absolutely.
Can I have?
Yes.
Are there any studies, a primary LT, like everybody goes for transplantation versus waiting for Kasai and proceed for transplantation? Are there any random control studies like that doing primary, every patient going for a liver transplantation?
No, there are no RCTs, but I don't think ethically somebody would allow you to do an RCT if a child comes at 60 days and you say that I will take this child for primary liver transplant. Nobody would agree because
But again,
it is not possible. That's what I told. It's a need of hour, but it is not possible to do an RCT. That's what I believe. I don't know what. Can we do an RCT?
Okay. Can I also answer a question if I'm chairperson?
Yeah, why not?
I think, just an answer to both the questions. I think Kasai is very effective in giving a lot of time for parents to actually think about transplantation. A newborn child, 30 days, 50 days, you're talking about transplantation. It's very difficult to actually convince the parents, more actually the grandparents, because they'll say, it's not worth the effort. And a Kasai is very useful for that. And in terms of doing a biopsy and then deciding, personally, I don't think there's any point in doing a biopsy and then deciding whether you want to do a Kasai or not. Before 90 days, unless there is obvious features of chronic liver disease, I would just do a small laparotomy, take a biopsy, if there is, and try and do a Kasai, as long as there's no ascites and the liver is not hard. Because whatever it does, even if it delays the transplant by a few months also, that actually works in favor of the child and the parents. And that's my opinion. I don't know if anybody has any other ideas.
Yeah, fair enough. Because you do the biopsy, you need a good interpreter.
Yeah.
That is always there. Who's used to seeing this biliary atresia biopsies.
Yeah, but I would rather believe my eyes than the biopsy report. So, okay, if that's it, then thank you. Thank you.
Yeah, thank you.